you that are not AGT members, please consider joining the organization of AGT so we can continue to hear your voice and understand the needs in the community and in the field.
Or molecules, it tends to make them more lipophilic. So, for example, bilirubin, which is hydrophilic bilirubin, which is a lipophilic drug or molecule that's produced in the liver as a breakdown product of heme, is primarily metabolized through UDP glucuronyl transferase. In individuals that have abnormalities of the function of this enzyme have hyperbilirubinemia syndromes, including Crigler-Najjar syndrome and Gilbert's disease, both which are forms of hyperbilirubinemia. These patients would also be at increased risk for toxicity if given the chemotherapeutic agent irinotecan, since irinotecan is primarily metabolized through this enzymatic pathway. So here, if one is considering the use of irinotecan based therapy in a patient with cancer, it is entirely reasonable to assess their UGT1A1 status to determine whether or not they may be at risk for having increased toxicity. Another form of chemotherapy, the mercaptopurines, which are purine analogs that interfere with DNA replication, are metabolized through a TPMT pathway, and there are about 4% of individuals, both in Caucasian as well as the African American populations, that show significant deficiencies in activity based on the alleles that they possess, and in this case would be the use of these drugs would be contraindicated in these individuals. So the next thing I want to talk about with regard to personalized medicine is hereditary cancer risk. There's been a lot of interest in the lay press following the revelation that Angelina Jolie opted to have prophylactic surgery upon following the knowledge that she bore a BCR mutation. And really, hereditary cancer risk is a very important element in understanding cancer risk. Fully 10% of all cancers are now felt to be associated with some form of inherited risk. Mutations in BRCA1 and 2 explain approximately 15 to 20% of hereditary breast cancer risk. They also account for a significant number of hereditary ovarian cancer risk. But now we're finding that there are a number of other genes that add to that hereditary cancer predisposition, including P53, P10, STK11, CDH1, and PALB2. There are also some important hereditary risk genes that are associated with colon cancer and lead to the colon cancer syndrome of Lynch syndrome, and there are some mismatch repair genes that can be interrogated to look for whether they're patients who have hereditary colon cancer risk. So I want to switch gears here a little bit and talk about some specific tumors and how theranostics and precision medicine is helping to redefine our understanding of these diseases, and certainly our our treatment of these diseases. And I'm going to start with chronic myelogenous leukemia. As I mentioned before, this is defined by this pathognomonic fusion protein, the BCR-ABL fusion gene, that leads to the development of a chronic myeloproliferative neoplasm. So what is CML? Well, CML is characterized by having a marked increase in peripheral blood neutrophils. The median white cell at presentation, patients with CML is 170,000 per microliter. These neutrophils show a marked left shift. In addition, there is basophilia and eosinophilia that is almost constantly observed. Interestingly, there's also frequently thrombocytosis or an elevated platelet count. In some cases of CML, in fact, the increased platelet count is much more pronounced than the neutrophil count. The bone marrow is characterized by marked granulocytic hyperplasia and presence of interesting micromegakaryocytes that are quite specific for this disorder. Below you can see a cartoon of the ABL and BCR genes. The fusion between BCR and ABL brings along most of the ABL tyrosine kinase, as well as varying amounts of the guanine nucleotide exchange factor, BCR. There are 3 different common forms of BCR-ABL fusion. The most common form that's associated with CML is a 210 kilodalton or P210 gene. There is a smaller version, P190 version, that has less of BCR that comes along, and that's more commonly associated with Philadelphia chromosome positive acute myeloid or acute lymphoid leukemia. So as I mentioned before, back in the early 2000s, the discovery of imatinib, which is a ABL tyrosine kinase inhibitor, has really transformed the treatment of CML. Patients who have CML can now be effectively managed by getting an oral daily dose of imatinib. And most patients who receive imatinib see a marked decrease in normalization of their peripheral blood neutrophil count. Typically within months, the count drops into the normal range, and in fact, when one looks by molecular PCR techniques for the presence of transcript, most patients achieve the major molecular response, which is less than 0.1% of the abnormal transcript in the blood. And if one obtains this major molecular response, then the likelihood that they will remain in stable remission over 7 years is quite high. Unfortunately, we do observe occasionally patients that over the course of time begin to see a rise in their BCR-ABL transcript. And we now have specific molecular tests which allow us to look to see whether or not they are developing specific mutations within their ABL kinase domain that lead to resistance to imatinib. And in such cases, depending on the mutation that is identified, one can convert the patient to either second or third generation tyrosine kinase inhibitors that are known to overcome that particular resistance mutation and are able to have patients go back into full molecular responses. Unfortunately, there are also some other types of resistance acquisition that can occur that aren't caused by specific mutations to the Abl kinase domain. They may be mutations in other myeloid genes that are associated with myeloid malignancies. For example, P53 mutations are very common causes of resistance and transformation in patients with CML, as well as other cytogenetic abnormalities that can be acquired that also lead to resistance. So the second myeloproliferative neoplasm that I would like to speak about is really a group of 3 myeloproliferative neoplasms: polycythemia vera, essential thrombocythemia, and myelofibrosis. And the reason I'm taking these 3 is these 3 encompass the majority of Philadelphia chromosome negative myeloproliferative neoplasms that one sees. Each of these different myeloproliferative neoplasms have very different clinical behavior. Polycythemia vera is characterized by an excess production of red cells. Essential thrombocythemia is characterized by an excess production of platelets. And primary myelofibrosis is characterized by an excess production of stroma within the bone marrow that leads to bone marrow fibrosis. Now, despite the very different clinical behavior of these 3 diseases, the vast majority of these diseases are driven by the same primary genetic event. It is a mutation in a signaling molecule called JAK2, and JAK2 V617F mutation is responsible for the majority of these BCR-ABL negative myeloproliferative neoplasms. And we're beginning to understand a little bit about what is underlying the biological heterogeneity, because we're beginning to understand more about the mutational landscape that exists within these tumors. And you can see on the right-hand side that there are a number of what we call secondary genes that have harbor mutations that we call secondary driver mutations that collaborate with the initial primary driver mutation to drive the disease phenotype. And I would just use this one example of the case of JAK2 TET2 mutated polycythemia vera and ET. So many patients who have JAK2 mutations also possess TET2 mutations. It's about a range of like 30% of the cases. If one looks at the development of the disease, and one can do methylcellulose culture of the hematopoietic colonies in a patient with JAK2 and TET2 mutated disease, and look to see whether or not there are JAK2 only colonies and JAK2 plus TET2, or TET2 only plus JAK2 plus TET2 colonies. And in this way, one can understand the clonal hierarchy of the tumors. And what Ortman and his colleagues were able to demonstrate was that there's a very different clinical behavior and potentially therapeutic response in patients depending upon the clonal hierarchy of their disease. If, for example, the patients had JAK2 mutated first, then TET2, they tended to be younger, more frequently had polycythemia vera than ET or primary myelofibrosis, had an increased risk of thrombosis, and also had a much more increased sensitivity to JAK2 inhibitors. Conversely, if TET2 was mutated first, then JAK2, they tended to be older patients who had either essential thrombocythemia or primary myelofibrosis over JAK2 and were less sensitive to inhibition of JAK2. So here you can see that by understanding the molecular landscape of these diseases, we get a better understanding not only of the biology, but also potential therapeutic responses. Another important area that I would like to speak of in the personalized medicine is that of immunotherapy. It is now clear that anti-tumor immunity represents an important aspect of an individual remaining cancer-free. It is well known now that certain states of impaired immunity increase the incidence of certain types of tumor. In fact, it's now known that increasing age is associated with immune senescence, which plays a role in age-related cancer risk. There are a number of different examples of mechanisms by which cancers escape immune surveillance as an important part of cancer progression. And perhaps most importantly, anti-tumor immunity is now being shown to be able to be manipulated and improve outcome. And this is really something we've known for a number of years, starting back with the advent of allogeneic bone marrow transplant. So allogeneic bone marrow transplant in patients with chronic myelogenous leukemia was one of the first treatments that was able to show curative definitive therapy for patients with CML. And in this particular case, patients would receive an allograft from another individual. In most cases, these patients would go into a remission. However, not infrequently, patients would undergo relapse with escape of the Philadelphia chromosome-positive disease in a patient that was fully engrafted. And what was shown was, as relapse was occurring in these patients, that a simple donor lymphocyte infusion frequently could induce the patients back into remission. So this very clearly demonstrated that there was an immunologic component to the ability of bone marrow transplant to induce remission and preserve a cancer-free state. Since then, there have been a number of different immunotherapies that have begun to settle into the cancer treatment landscape, and I want to just touch on two important new immunotherapies that are making big splashes in the cancer field. The first are CAR T cells. These are chimeric antigen receptor T cells that have a chimeric T cell receptor that includes a portion of an immunoglobulin domain that is specific against a target on the patient's tumor, that these T cells are engaged to specifically interact with the tumor cells, eliciting a potent anti-tumor response. So the way this works is a patient's own T cells are collected. Then specific CARs are engineered and introduced into the patient's tumor cells by transduction technology. These CAR-engineered T cells are then infused back into the patients, frequently showing remarkable immune responses, frequently leading to patients going into sustained complete remissions. In fact, some of these are so potent, particularly in patients that have high tumor burdens, that a life-threatening tumor lysis syndrome can occur because these CAR T cells are so efficient at attacking these tumors. So the second area of immunotherapy that is making splashes in personalized medicine is the PD-L1 targeted drugs that are called checkpoint inhibitors. So PD-1 is a molecule that is expressed on T cells, and PD-1 binds to its cognate ligand PD-L1, and this interaction leads to inhibition of T cell mediated cytotoxicity. Now this is a very important element of our immune system because its primary role is to prevent autoimmunity. But in the case of tumors, some cancer cells will upregulate PD-L1 on the surface of their cells thereby suppressing T-cell mediated tumor attacks. So immunotherapies have been developed that employ monoclonal antibodies that block the interaction between PD-1 and PD-L1 and have been now shown to have significant anti-tumor immunity in a number of different cell types. So recently there have been 2 drugs that have been FDA approved, one being a drug by Merck called Keytruda, and one BMS launched Opdivo. BMS has received approval for Opdivo in melanoma, and now both drugs have been approved for indications in non-small cell lung cancer as well. In combination with the FDA approval of the 2 drugs, there were diagnostic companion tests that were released at the same time with FDA clearance. For Merck, there was a companion diagnostic, and for Opdivo, there was a complementary diagnostic, and we'll talk a little bit about what that means in a moment. So the FDA approved these drugs for the treatment of non-small cell lung cancer. Currently, PD-L1 is being investigated in a number of different tumor types. As you can imagine, it's not really, it doesn't depend on what the tumor type is, just whether or not they express PD-L1 or are targets for the PD-1, PD-L1 T-cell pathway. So there are a number of studies that are occurring in the different cell types, and this is influencing physicians to order off-label these tests to see if perhaps these drugs might work in these tumors. But it's important to be cautious because these different tumor types are now we're finding that there are different cutoffs for PD-L1 expression, and that have significant influence on the responsivity of the various tumors to the different drugs. So here's an example of a tumor with PD-L1 expression, and this is a lung cancer with a tumor proportion score of 50%, meaning 50% of the tumor cells are expressing PD-L1. In such cases, for both the drugs, one would anticipate there to be strong response to the PD-L1 drugs. Conversely, this is a tumor that has relatively low tumor proportion score, 5%. In the case of the Keytruda with the companion diagnostic, a proportion score of 5% would be below the threshold that one would, the data would suggest that there be clinical benefit for getting the drug. Conversely, for Opdivo, the clinical benefit, while it increases with the proportion of cells that are positive, even at a negative tumor proportion score or 0 tumor proportion score, the patients do as well with Opdivo as they do with standard chemotherapy. Because of this, the FDA has designated the companion test for Opdivo as a complementary diagnostic. And the reason for that is because the patients do as well if they don't express PD-L1 as they do if they receive standard of care chemotherapy, then one really does not need to demonstrate expression in order to get the drug. However, there's very clearly an increased response to the drug when there is increased expression of PD-L1 on the tumors. The diagnostic test that was associated with Keytruda, on the other hand, was released as a companion diagnostic. And the reason for this was that they're very clearly at low levels of expression of PD-L1, the patients did not do as well as the standard of care therapy. So really, the companion diagnostic informs on which patients would respond and which patients would not respond to the drug. So as we go into this era of solid tumor precision medicine, we're now seeing that there are a vast number of different pathways that solid tumors utilize to deregulate cell growth and evade the immune systems. As one looks at a variety of different tumor types, one sees that there are certain genes that are mutated specifically in certain entities. However, there is a lot of overlap between different mutations and different tumor types, which is leading to a concept of, rather than treating patients purely based on the histologic subtype of the tumor, that perhaps there can be strategies that are based upon the mutational landscape of the tumor. So again, here we can see various cancer pathways with targeted therapies and the different tumor types that are associated with response to these drugs, and you can see that some of the drugs have activity in different forms of cancer, really making a more complicated and nuanced landscape for deciding what therapies to use in solid tumors. One of the important associations that needs to be understood is that there are levels of evidence that are associated with different gene mutations and their different approved therapies. And really, level 1 approved therapies still only reach a relatively short list of approved markers or drug associations. So there's still a lot of work to be done, and it remains to be seen, for example, if one identifies a BRAF mutation in a tumor type that is typically not associated with a BRAF, whether BRAF targeted drugs will work in that setting. So for lung cancer, we have a number of different genetic alterations that are associated with level 1 identified targeted therapies. In fact, we're even now, for the EGFR mutations, there are resistance mutations that have been identified, the EGFR T790M, that now there is an approved drug that specifically targets that resistance mutation, similar to what was observed in CML with the Abl kinase mutations. So we are now starting to see an era where we're going from these current targeted tumor panels, as we see for lung, colorectal, and melanoma, to broader multi-gene panels that are being run by advanced sequencing methodologies such as next-generation sequencing. And one can see that when one looks at these broader mutational panels, that the mutation distribution shows that most tumors have more than one mutation that can be identified, in some cases upwards of 4 to 5 to 6 different actionable mutations that can be identified, raising important questions of are these making these patients eligible for targeted therapies that might improve their outcome.
Dr. Recchi, I think it's 1 o'clock. Do we have more time, Christy, on this, or?
Yeah, we can wrap up in a couple minutes if that is.
I'm very
with Dr. Recchi. Okay, thank you.
So as we go to this era of larger panels, the question of actionability really becomes an important one, and this is where guidelines and the FDA labels really are helping to formally define these criteria. We fully anticipate that a number of these genes, as the level of evidence increases, will become actionable, if not now, in the very near future. So when one considers one of these sequencing panels in an NGS report, not only does one need to identify, provide the mutations that are identified, but really is now incumbent upon laboratories to provide clinical relevance. Are there national and international guidelines based upon these findings? What are the treatment options? Are they tumor specific, or are there options in other tumor types targeted towards these? Are there clinical trials, and what is the level of evidence? These are all very important elements that we need to consider as we embark upon these larger panels. Now, there are even larger panels that are being introduced into the field, 300 to 400 genes, and it really raises the question, what is the level of evidence for the identification of these mutations in the genes, and how are they helping clinicians to provide care? In fact, now it is within reach that we can do whole genome or whole exome sequencing, and with or without comparison to germline, which is another important consideration to know whether these are acquired somatic mutations or predisposition genes. And finally, there's been a lot of press lately about the liquid biopsy, which is free-floating DNA in the plasma. Certainly there are a number of potential utilities for the liquid biopsy, including primary diagnosis, drug selection, or monitoring of recurrence, but these have yet to reach the level of evidence to be a standard of care. So it's not so simple. We have to recognize that tumors are heterogeneous, that metastases differ from primaries. Tumors can evolve and become resistant, which necessitates perhaps multiple tests in individuals to ascertain that kind of resistance development, and certainly all of these are in a very tight reimbursement climate. So with that, I'll summarize by saying that personalized medicine utilizes a patient's own genetic makeup to inform the physician on aspects of the response to certain therapies to individualize treatment. Precision medicine interrogates a patient's tumor genetic makeup to tailor therapies that will be most effective while hopefully minimizing side effects. And both targeted therapies and immunotherapies offer great hope in the fight against cancer. With that, I will entertain any questions, and I thank you for your attention.
Thank you, Dr. Raggi. I don't see any questions. Christy, do you see any questions?
Not yet.
Okay, so for the attendees, if you feel there's any questions that you would like to input, please do so. We're going to give it one more minute to see if there's any questions. Okay, so if there's no questions, provided, we want to thank you for your attendance on this webinar. We also want to thank you, Dr. Raggi, for a very informative and productive webinar. We appreciate your time and your effort, and thanks everyone, and have a great day.